If you talk about premium implants, then maybe in Europe it's Nobel Biocare, Straumann, and AstraZeneca.
Okay, great. I'm sort of going to ping pong back and forth, and doctors, if you have something to add, just feel free to jump in. Dr. Bhatt, NobelActive has been one of the top implant systems in the world and was introduced, technically over a decade ago. Can you talk about the points of differentiation with that system, why it's been so successful, why it's been so durable over a number of years, please?
Well, it's pretty aggressive threads. It does anchor well to the apical part of the site. Had been studied in large volume in controlled studies. It anchors very well, so it provides early loading possibilities. So it has been successful.
Okay. And just in your view, still great system, but just ready to be iterated after a decade plus? I mean, is that sort of your view?
It's a great system. There are other systems within that company, such as the Replace, that are also long-term being used and long-term being studied. So it's personal choices of a clinician.
Okay, great. Dr. Stas, I want to continue to sort of do some high-level build, and then we'll get more into the specifics of N1. Can you briefly discuss how Straumann's BLT was able to differentiate itself from NobelActive and other premium offerings out there? Clearly, we've heard a lot about BLT, but maybe talk to that offering from Straumann and how it compared and contrasted to the other premium implants that were already on the market.
Yeah, for me, I was in the pre-launch of NobelActive then days, and to be honest, the Straumann group, the ITI group, thought it was not a good idea to use such a more aggressive implant. And so I was surprised when I was invited also with the introduction of BLX. And in my opinion, but I don't know what Bhatt thinks about that BLX comes very close to NobelActive. And in my opinion, with BLX, Straumann is closing the gap between Nobel Biocare and Straumann in the way of early loading and like Bhatt said, better anchorage for mainly immediate implants.
Okay. Dr. Stas, maybe just walk us through market share at your practice. I mean, you mentioned a tremendous amount of implants per annum. I think you mentioned up to 2,000. Talk to us on how the market share couple of years ago and how it looks, today as we sit here in 2020.
Yeah, you have to understand we have a referral office, and in a referral office you try to just have 2 or 3 systems for your referrals. Otherwise, it gets very difficult. In our own office, we use mainly Nobel Biocare products. We did a lot of like Bhatt Nobel Replace, but then you have to understand we do a lot of immediates in the aesthetic zone. And there, NobelActive is our first choice. In the lateral parts, we use Replace or Parallel. We do use some Straumanns, but I have a private office, but I work 2 days a month for a big chain. And there is a Straumann or our product or our manufacturer. Market shares, I think in Holland, for the dentists, Nobel Biocare is the biggest. For hospitals, because we do a lot in hospitals and a lot in private office. Straumann is bigger in hospitals than Nobel Biocare, and Astra is the smallest of the 3 big ones here.
Okay. I'm going to jump around a little bit. Dr. Bhatt, over to you. Here in the States, we've heard from Envista about a new implant system coming. It's called N1. I think we're all trying to determine how excited we should or shouldn't be in coming quarters and years. So start at a basic level, and I'd love to be able to get deeper, but I think it's important to start at the basic level. Can you talk about the N1 implant system and maybe its key points of innovation that we should make sure that we understand here?
Yes, it does change, in my opinion, the paradigm of implant dentistry. The main point for me is the OsseoShaper because it provides drilling at slow speed without generating heat and without the refill rinsing or irrigating, which is in all other system, you need to irrigate to make sure that the drill does not overheat. So for me, this is the most important part of the new system.
Okay, and I'm going to ask you to elaborate. I'd like to spend some time here. No heat. I hear no heat, and I think less cell death. Is that fair? Maybe if you can talk about the importance of no heat and also no irrigation, if you can expound upon that.
Yeah, well, of course, when you drill into any bone, whether it's oral or orthopedic, you try to reduce the heat that is generated by the drill. And drilling at a fast speed also, especially with heat, will kill the cells, obviously. So being able to drill at low speed without generating heat is a major advantage on cell death. Secondly, because you don't irrigate, the bone chips are left within the osteotomy and they provide a faster healing.
Okay, great. And I'm going to continue with you, Dr. Stoss, and I want you to get in there and give us your opinion. So what does that mean in terms of outcomes? When we think about bone chips faster healing, is there a lower failure rate associated arguably with an N1 implant versus maybe some of the other premium systems that are out there?
Yes, we surely think so. You have to understand when you place, nowadays, a lot of patients wants to be immediately restored. So they leave the office with a temporary crown on the implant. And if you have some cell death, then after 2 weeks, the implant is more vulnerable to overload. So if the implant is more stable, and it is more stable if you have less cell death, you can more easy make your temporary crowns, and we think also faster make the final crown. So for the patients, it's a lot of, how do you call it? it's better for the advantage for the patient. It's better for the patient.
Got it. And Dr. Stoss, anything, if you want to walk us through, I just want to make sure I'm getting both of your opinions. When we think about the key differentiating factors between N1 and you're using a wide array of other premium implant offerings, what else would you call out? I mean, is it what Dr. Bahat touched on? Feel free to elaborate on some of the other things that you think are critical to really understanding the N1 implant system.
Yeah, I think I totally agree with Odette about the surgical part. But we also have to look at the parts who are on the system. And then it's what I mean, the abutment. The abutment is the piece, which is the connection between the implant and the crown. And nowadays we looked in 55 years, we have implantology, and we focus a lot to osseointegration. And osseointegration is of course important. Without osseointegration, we have no implants. But there is one thing very different on a dental implant. This dental implant has a crown, but it sticks into the mouth. So it has to be sealed. And this sealing is on the abutment. And in my opinion, it's not only the surgical part, but especially also the abutment and what we call the immersion profile, the shape of how it's coming out of the bone into the gum, into the mouth, is very important to have a good seal for the future, because a good seal is more predictability of your results on the long term.
Okay. And maybe to push you there, Dr. Stoss, and then Dr. Bahat, I'm going to go over to you. It's funny, a lot of the premium implant offerings, they all sort of refer to or call themselves a system. Dr. Stoss, I don't want to put words in your mouth, but based on what you just talked about, it seems that this might really be a system. There's different components, and it's all sort of critical to the outcome. Is that a fair assumption? And is that how you really view N1? And is that part of what differentiates N1 versus some of the other premium implant offerings?
I think what you say is really correct. We looked a lot at an implant, but we have to look at a complete system, because only when the system is really fitted all together and the right dimension, right materials, and the right way, we can use it surgical. In N1, for example, it's possible to place the abutment in the surgical part, so it is not contaminated or don't go to the lab. And that's why we get better osseointegration. So for me, an implant is not only the implant itself, but you really have to look at the complete system. And in this case, in N1, it's really developed as a system.
Dr. Bahat, your thoughts there, if you can talk to that, please.
I agree to some degree and disagree on other.
Please, we love agreement and disagreement.
I know you do. It is a system, period, for different reasons, additional reasons to what was mentioned by Tristan. It is a system top to bottom, but there are other systems available. There is no study to date, to my knowledge, with regards to better seal or better reaction to soft tissue on the N1 versus many other existing systems on the market. It is a system that will never replace judgment, like no other system will replace proper judgment. And I do not want to make it light that, well, we have a system, therefore mistakes will not happen. That's not true. Surgical judgment, but clinical judgment will always supersede the system. But this is a system top to bottom. That is true.
Okay. And helpful color. Dr. Bahat, maybe if you could just help us out with how many patients have you treated with N1 to date, approximately?
Well, as you know, it's not approved in the US yet. So the patients that I've operated per request were in Germany and Spain. Mm-hmm. And the one that we operated actually by choice were patients that on classification of patients, they would be regarded as highly compromised. And we wanted on purpose to do it on compromised patients because we wanted to show the validity of the implants, not in more straightforward situation, but in much more complex situations. And it worked very well on those.
And I want to push you a little bit there, and then Dr. Stoss, I'm going to jump over to you, but how is this system ultimately going to be used? I mean, you just mentioned when you opted to use N1, it was in that highly compromised case. The way I look at it, there's no such thing as an easy implant case. That's from a Wall Street perspective, but clearly some are easier than others. And so when we think about N1, is it, hey, you know what, great system, but really suitable for the highly compromised patient? Is it all across the board? Maybe if you can help elaborate on that, Dr. Bahat.
Me?
Yes, please.
Well, use it in, as mentioned, in the most compromised areas. So we use it in aesthetic zone because, of course, it shows, and of course, a tooth in the front is different than a tooth in the back as far as aesthetic judgment. We used it in compromised bone, that is to say, when the bone was insufficient or poor quality or needed to be grafted. We used it in immediate extraction because the assumption on all systems is if you can be successful in immediate extraction, and the next step is can you immediately load it. We used it in a sinus graft situation, that is when you don't have adequate vertical bone over the sinus. So you graft the bone into the sinus, and we immediately place the implants. Not too many tests were done on that. We use it in a pterygoid, which is in the mouth behind the tuberosities, which is always compromised bone, both in quality and height. So the use was on purpose, directed to the most compromised situation, and it worked very well.
Okay. And one more for you, Dr. Bahat, and then Dr. Stoss, I want to head over to you. But so that was great color. What % of your overall implant cases sort of fit those various definitions? In other words, let's fast forward and this is approved in the US and you're able to bring it fully into your practice. Does the N1 system account for everything that you just laid out? Is that 10% of your cases? Is that 80% of your cases? I'm trying to see how prominent N1 might be at your practice upon approval.
You asking me?
Yes, sorry, one more for you, and then I'll go over all Bob.
Because I was happy that Dr. Strauss would be coming operating in the US. I cannot answer that because I do use other successful systems of Nobel. The system is very appealing, but I'm sorry, I cannot give you percentages.
Okay. I'll come back and find another way to push you or ask you for some percentages. But Dr. Staes, over to you. And you're joining us, as you mentioned, from the Netherlands, and you're not confined from an approval perspective. The N1 patients to date, the outcomes that you've seen, let's maybe pick up there.
Yeah, we did, I just asked, we did 230 cases till now. With big success in as Bahad already said, starting with complicated cases, but also easy cases. Nowadays, I think in what we do now, it's about, I think, 20 or 30%. That's because of we don't still have all the implants. We need some longer ones and maybe some wider ones to do all the other indications. I think when we have everything, I think it can be 70 or 80% of the cases. There are still cases where you need another implant system. For example, in the lower jaw, especially posterior, bone is mostly too dense to use this system. Then it gets more difficult. But in the complete upper, in immediates and extraction sites, it's really my first choice nowadays.
Okay, that was great color. And so just to be clear, let's fast forward. Out of the 2,000 implant procedures that you might be doing annually at your practice, ultimately you feel that N1 could service effectively 70 to 80% of that overall volume.
I think when we are in 2 or 3 years, this could be the case. And you have to realize that we do a lot of anteriors. I think in our office, 60% of the cases we do are anterior cases.
Okay, and so help us out, Dr. Staes. What would this theoretically, and theoretically, what would this be replacing? From another manufacturer perspective, you mentioned in the anterior. What are you using? What could you see this replacing when we think out and N1 having that bigger presence at your practice?
Yeah, we use a lot of Nobel Active now in the anterior, but the same story for BLX in the other office. And for me, you have to realize we have a referral office. So we try to standardize for the referrals. And I think N1, when the assortment is full, is completed, then it's easier to use also for the referrals. So that's also important for us.
Okay, great color. Dr. Bahad, back over to you. And, when I had the privilege of talking to both of you guys in advance, I said, whatever you can do to dumb it down from a Wall Street perspective, we'll take. But just help us out. We hear about the simpler workflow behind N1, fewer steps, lower speed drill. But can you walk us through currently on a competing system, help us out what that entails versus for an N1 implant, what that entails and where there might be fewer steps or simplification along the way?
I will only talk about the Nobel systems.
So you're going to compare N1, I'm sorry, doctor, versus...
I'll compare it to the active that you requested to replace, which are the two main systems. I do not agree with Tristan regarding the posterior mandible or anterior mandible, because it's certainly a drill for hard bone for the N1. So if you really wanted to replace a system, you can replace it all. It's not what I would do, but there's an option for that as well. Regarding the drilling sequence, the drilling sequence is built on biology in which you sequentially enlarge the site. We call it osteotomy. So if you want to go for a given diameter, you will have multiple drilling sequences to enlarge the site. So the implant can be stable, yet it will not basically destroy the bone. And all that is done with irrigation. My take on that is the more drilling you do, the more mistakes will happen. Just imagine that I'm That's for you, Jonathan, so even you will understand. So when you drill into concrete and you have to drill to a given diameter, and you use multiple drills, and the site is narrow, your drilling will never be in the same direction unless you're a robot. When you drill into plywood, of course, you'll reduce the number of drilling sequences. And the more you drill, the more there'll be variation between the site and the diameter of the future implant, correct? So with the N1, you basically have two drilling sequences. And that is, again, what I said in the beginning of the questions by you. You drill with the one which is called an osteodirector, which happens to be very sharp and draws into the site. And then you follow up with the OsseoShaper, which really prepares the site completely. So you have two drilling sequences, period, unless it's a hard bone. And in a hard bone, you have a special drill for that. So instead of, let's say, if you use active or replace, in which I will have to have 3 or sometimes 4 sequences, you'll have 2 only, because the OsseoShaper is a dedicated shaper for a given diameter, period. The advantage that I see in that, besides the obvious biological advantage, is that the less you drill, the more accurate you're going to be, period.
Very helpful. And I'm going to run some of that back by you, Doctor. So 2 drilling sequences versus on Nobel Active prior, maybe 3 to 4, fewer drilling sequences, fewer mistakes per your analogy. What about time? What about efficiency? A surgeon like yourself, very busy, high demand. What would this do from an efficiency standpoint at your practice? Were you able to do, X before, but now under N1, you might be able to do 1 or 2 incremental procedures per day? Maybe talk to that. I would think faster hearing 2 drilling sequences versus 3 or 4, but maybe you can elaborate on that.
You're asking me or you're asking Tristan?
You, Dr. Bahat. Yep.
I don't look at it in surgery that way. That's when you set up for mistakes. Doesn't matter what system you use. If it's a 2 drilling sequence or 3 drilling sequences, it's a question of seconds or a minute, which that is not important in surgery. It's not the patient is on some kind of a vital machine to survive. I don't see it at all. What I see is that the more accurate you're going to be, the less the mistake, and it's algorithmically increased. Once you end up with the wrong direction of an implant, then you have to restore in the wrong direction. Then you're setting up yourself later for overloading or non-axial loading for down the line mistakes. But to say that, well, because I have 2 drilling sequence as opposed to 4, I'll finish 30 seconds earlier, my advice is go to another surgeon.
Okay, fair enough. Dr. Stas, is it fair to say that you're not going to buy into the efficiency argument as well? I mean, incredibly busy practice, 230 N1 cases. Is there a part of this where you're seeing the ability to do an extra procedure or so a day, or no, for you, that's not part of the equation either?
No, I agree with Odette. It's a matter of seconds. That's not the biggest advantage, but there are 2 others. Because it's quiet and not a lot of water, it's more comfort for the patient. And when it's more comfort for the patient and the patient is more comfortable, then it's easier for us to work and to place it really on the correct side. So because of this only 2 drills, in fact, it's 1 drill and 1 OsseoShaper, it's easier to work. It's more relaxed in the room. So this is an advantage. The other thing is cleaning. We in a big office as we have, if you have to clean all the drills and the complete surgical set, it's a lot of work for sterilization. We have 4 rooms where we work all next to each other, so it's very busy. Then cleaning the small set and only 1 drill, this is an advantage in time for sure.
Interesting. So it might not be the 30 or seconds that you might save on, 2 drills versus 3 or 4 sequences, but to your point, turning over the room, cleaning all the different instruments, that's where your practice might actually see some true efficiencies from N1.
True.
And Dr. Stas, to stay with you for a moment, again, over 200 N1 cases, What have you witnessed to date, outcome wise? Maybe when did you do your first implant? We hear these really high failure rates, of course, not with you guys, with N1, with implants, pardon me, but we hear just in general part of the shortcomings of implants are the failure rate. So have you been able to identify at your practice, here we are 250 implants into N1, really be able to identify better outcomes for the patient? I'd love you to comment on that, Dr. Stas.
No, I think that's difficult to say on scientific base with only 230 placed, and I think maybe 100 final restored. But we see very nice bone reaction. We load them a lot and make the impression for the crown faster than we did. And till now, we are very successful with it, and it feels good. And it feels nice when you place in the bone, when you put a lot of implants, and sometimes it's invasive sometimes to make a preparation on osteotomy, and it feels very good to place it like this. So from a biological point of view, I'm very confident that the results will be good.
Okay.
It's too early to tell you about really results on a scientific way.
Okay, great. Thank you. Dr. Bajado, over to you for a moment. We've heard this type of a platform was a long time in the making, and there might be certain things you can or can't disclose, but can you help us out with that? In other words, we've heard, where's the innovation from Nobel, and here's Straumann with a bunch of different systems and taking share. With what you're able to disclose, take us back to the early days where there was the sort of the thought process of the N1 system and how that came about. That'd be great.
I will not talk about systems that I don't use. And
I'm talking about N1, Doctor.
Okay. Regarding N1, and again, there's certain things I can discuss. Well, it took a while to come up with ideas. It took a lot of engineering power and scientists. We were very few clinicians in the beginning. I think the initial meeting was about 5 years ago. We were only 4 clinicians involved worldwide. The thought process, of course, was led by a biological concept. And it was, as mentioned before, don't destroy the bone, maintain the vitality of the bone. If you maintain the vitality of the bone, then the healing would be faster. That is obvious in all specialties that deal with bone. If the healing will be faster, you can complete the treatment faster. Regarding success and failure, it's too early to say. There are no data to compare. And other systems with other companies and Nobel that have long-term success rate, published in scientific manner. So it's well too early to say that a system will replace another system. Biologically, it has a lot of merits. There's quite a few papers that came out from Stanford, led by scientists there, to show that biologically in animal models, it's a great benefit. But as I said before, nothing will replace clinical judgment.
Okay, great. In the 5 or so minutes that we have left, I'd love to talk about the learning curve. You guys are world-renowned surgeons and highly skilled. If Envista is going to be successful with this platform, they're going to have some broad adoption for it. So, Dr. Stas, talk about your learning curve with N1, and then you mentioned all the colleagues at your practice as well. Maybe if you could talk to how it was rolled out to your colleagues, and was it easy? Where was the ramp? I'd love to hear about the uptake of the system and how difficult or easy it is for some of your colleagues to get their arms around.
Yeah, we started already for more than 2 years ago to try and to see how the osteotomy works, because it's different with the OsseoShaper. But in fact, surgically, it's not so difficult, because you have to make one preparation in the correct position, and then you have to be sharp, and then the OsseoShaper will follow this preparation. So it's just a protocol you can go, and then most of the implants you can just placed by one time drilling and one time the OsseoShaper. So the learning curve there is not very difficult. I disagree a bit with Odette about using it in all different situations. The difficulties are there when it is different and you cannot go with the OsseoShaper first time in, and then you have to use other drills or other things to place, and then there is a kind of learning curve. On the other hand, in building, we use another screw for wood than for concrete. So that's why in our office, when it's dense bone, we go to another system. When it's easy to place, we expect easy to place, mainly in the upper or immediate, then it's really easy system.
Okay. And Dr. Stas, just a couple of follow-ons there. I'm going to make up some numbers, but for a new system, when you were getting your arms around BLT or BLX, is it 10 cases until you feel like you're fully up to speed on is it 20? And whatever that number is it the same for N1? Is it higher or is it lower? I'm just trying to figure out relative to other novel implant systems, is this easier or more difficult?
I think the jump from Replace to NobelActive, that's what we did in 2007, was much bigger than now going from NobelActive to N1.
Okay.
One is much easier to adapt. And of course, we did also BLX, but then we were already trained in NobelActive. I think the jump from a what we call conventional implant to an implant shaped like NobelActive, but more aggressive threads, that's a bigger jump.
Okay. Dr. Baha, your thoughts there? Let's stick with Nobel. I know you want to keep it to their platform. How about that jump from NobelActive to N1? Do you think it's relatively straightforward? Do you think that's going to be a hindrance to adoption, widespread adoption of the system when you think about your constituents and your colleagues?
Well, I think that the N1 will be more similar to the Replace because the penetration of the Replace is 1.2 millimeter per revolution, which is much more similar to the N1. The Active is 2.4 millimeter per penetration, per rotation. So it's a much more aggressive pitch thread. So from a technical point of view, the jump from Replace system to the N1 will be simpler. The important part that was not touched upon is that with N1 being able to reduce the number of drilling sequence, it may be easier to jump for people who are not experienced as opposed to the experienced ones.
Okay.
Agree.
Okay. And so maybe that last comment and just a couple more questions here as we'll unfortunately have to conclude, but we hear a lot about general dentists wanting to take up implants, and I'm sure there's pros and cons, and we could talk about how experienced they are or aren't. So I know this might be a little bit of a sensitive topic, but is N1 ideally suited for a general dentist who might want to dip a toe in performing implants, or no, this is not the idea? I mean, I think about, fewer drill sequences, and a lot of what you laid out seems to imply that it might be more straightforward, but I'm just curious, out of the specialty, do you think it's appropriate for the general dentist? Dr.
To me?
Yeah, sure. I want you both to answer if possible. We'll let you kick it off.
The problem with the GP, it's not this implant system doesn't compensate the lack of knowledge, and the problem in my opinion, implantology is not about placing the implant. It's first about planning and treatment plan. And yes, if you are able to do that, then I think N1 is an easy system to use.
Okay.
But it never replaces knowledge about implantology, biology, and planning.
Dr. Bhatt, I think I might know how you might answer this one, but why don't you go ahead? Is this suitable and appropriate N1 in the hands of a general dentist?
I'm happy you got educated. I think that, and maybe in a minority, the separation should not be between the general dentist and the surgeon and the periodontist. I've seen some general dentists that do it excellently, and I've seen some of the specialists who do not. And failures occur to all of us. Okay?
Yep.
But of course, if somebody is less experienced, it's the same thing like somebody who's experienced. the more you can cut the number of possible mistakes, the more successful you can be.
Okay. Let me end here by trying to throw a couple of numbers your way, and we're numbers oriented. Dr. Stoss, let's start with you because you might be able to opine upon this a little bit more. Fast forward a number of years, for your Noble Active cases, does this completely take over or cannibalize Noble Active and maybe a little bit of share from others? I'm just trying to figure out N1 at your practice in a couple of years, how it's positioned. Does your overall Nobel share go higher, or does N1 just really replace the vast majority of Noble Active implants?
Yeah, for us, the Nobel share in the office is already very high, but in the external clinics where I work, it will replace other implants. That's what I expect. But it will take some time because we really have to grow the portfolio, grow the length and abutments and crowns. But in the end, I think it will replace in our office a lot of Noble Active cases, and in the other office, a lot of BLX cases. Yes, for sure.
Okay. And when we're hearing about a 10% pricing premium or double digit, is that fair in your opinion when we think about how they're going to roll out the system, a double digit premium for the N1 system?
Is it fair? Yeah, I think it's not only the implant you pay also the OsseoShaper. And for us, the abutments and restoration is much easier because we can do a lot of one abutment one time, which is in a referral office very important to avoid mistakes in the restorative for the dentist who restore these implants.
Okay. And Dr. Bahad, I'll conclude with you, and I'll sort of put it into a scale. We've all been waiting a number of years for innovation out of Nobel, and here it is, and it's out in Europe and it's coming to the US. How does this resonate? How excited should we be? I mean, I sort of do these scales of 1 to 6. Is this a massive step function in innovation? Very material? Is it somewhere in between? Just any commentary, any numbers that you're able to allude to would be helpful, and we can conclude.
Cannot give you numbers. It's like you're asking somebody on pain threshold, if it was yesterday 10, what is it today after you give narcotics? Cannot give you that. In my office and some of the top specialties that I do know, it will replace, it is a system, so it will replace some systems. I think it will be also replacing to a degree the replace system, not just the active. I don't see the way that Tristan looks at it because the active is extremely aggressive system, and as far as threads, and as far as gradients of surface. So though the active is a newer system that they replace, I think there will be also reposition of the N1 towards the users of the replace system.
Understood. Okay, great. Gentlemen, we have to conclude there. Doctors, thank you very much for your time. I appreciate it. It was great to pull in the globe, and Dr. Stoss joining us from the Netherlands, and Dr. Bahad, it was great to meet you, and best of luck, guys, for the balance of the year. Happy holidays, and I certainly look forward to reaching back out to you in coming months, and maybe we can discuss where the system is at that point in time. But thanks again, and take care.
Thank you.